All right, our final speaker in the session this morning is Dr. Curtis Rogers from the Greenwood Genetics Center. Curtis is a clinical geneticist and will be speaking to us today on finding pearls in a sea of skeletal dysplasias. Thank you, Curtis.
So seriously, unless you miss my Kenny Chesney, said Madonna, so 1990s, but I would like you guys to keep a little girl in your prayers. Her name is Skyla. She's one of my patients, and she has a rhasopathy, and her mom sent me an email this morning and said that she's been battling leukemia for a year now, 2 different types of leukemia. And they have decided that she is no longer a candidate for therapy. So just pray for Skyla and her family. But let's get on with this. I'm going to talk about 2 different disorders. One is Stuve-Wiedemann syndrome, well described but very rare autosomal recessive condition, and a fairly newly described carpofacial syndrome. I'm going to tell you about the gene, the candidate gene that has now been confirmed for CSCF syndrome, and after I tell you that, I'm going to have to kill you. So, because this is not yet published, it will be out soon in the American Journal of Human Genetics. First, patient MM, who presented to Shriners Hospital in our town of Greenville, and she came in. Her history was that she was a little premature. She's from Romania. Her family has moved to the Atlanta area, and she happened to be seen at Shriners for her skeletal anomalies. She has a very complicated medical history. She had some delays in walking due to her skeletal problems and prematurity, but has normal cognitive development. And this young lady is fluent in both her home language in Romania, which is what she hears at home, as well as English. And she's had multiple orthopedic surgeries. The thing to focus on is she's had recurrent unexplained fevers and joint pain. Her family history, while initially said to be negative, when I had a face-to-face interpreter, and the Lord blessed me with a Romanian medical student who happened to be rotating in my office when the family came back the second time, and so I took her with me, and she was able to tease out from them that they are from the same small community in Romania, and indeed they are second cousins once removed. So on her initial physical exam, you can see she's short. Her head size is okay given her weight. And I'll show you a picture. She has mild facial dysmorphisms. I think a lot of it more due to her dental anomalies, severe scoliosis, and shortened extremities. And you'll notice some joint contracture. She has extreme joint tenderness too. I mean, just palpating her joints made her extremely anxious. And you can see these very unusual, let me see if I can do this, very unusual appearance of her knees and her scoliosis here. And a little bit closer view of her knees, camptodactyly here, and the joint contractures that she had. And here you can see her x-rays demonstrating her scoliosis. And these very unusual appearing bones with this kind of lucent striated appearance. And these bones are also shortened. I think you get a better look here at her ankles, at this flaring, almost an Erlenmeyer-Flass type of look with these striations. And you can see, and her hips are very dysplastic here. So, wide and blurred margins of the metaphyses, the bowing of the long bones, and this very unusual appearance of the metaphyses and destroyed femoral heads and scoliosis. And she has, no wonder her joints are tender, because she has a highly elevated SED rate and C-reactive protein. So this is an inflammatory process that's associated with the skeletal dysplasia, and that's where her unexplained fevers are coming from. Not surprisingly, she had loss of heterozygosity, and this block that I've got boldened here is where the gene LIFR that causes Stuve-Wiedemann syndrome is located. And when her testing was done, and this testing was done in Germany by Dr. Losch, and we found that she is homozygous for a one-pair duplication. Obviously, this is a disrupting variant and causes a stop codon. So the Stuve-Wiedemann syndrome, has anybody ever seen this condition? I don't see any hands going up. Oh, we've got one person here. Okay. Pretty rare condition, and thought to be autosomal recessive because of consanguinity in affected siblings, and was first described in 1971. And I can tell you, I had not heard of this condition until I saw this young lady, and she's the only person I've ever seen in 30 years, so I think that's pretty rare since I go to Shriners Hospital all the time. So the key feature here is not just the early lethality. Where'd it go? There we go. Well, forget that. Early lethality and hyperthermic episodes that are unexplained. So these fevers of unknown origin, which are recurring, and the joint pain, and then you take these x-rays and you have very unusual appearing bones. Feeding and swallowing difficulties that are so severe, many of these children do not survive through the first year of life. Mildly dysmorphic features. And if they do survive, then they're going to have progressive scoliosis, can have spontaneous fractures, and a lot of these other problems that look like a dysautonomic process. If you look at the gene LIFR, or leukemia inhibitory factor receptor, you can see that this has been described in 19 families in this study in 2004, and that most of the mutations are variants predicted premature termination or were disruptive in nature, and this affects the JAK STAT3 signaling pathway. And here's our patient's gene alteration. This is not her, but this is the identical change that she has, and is certainly felt to be pathogenic. What does LIFR do? And I'm not going to get into this a lot, but by binding and inducing signaling in JAK-STAT and MAP-K pathways, it alters not only your immune system, but your bone formation, and may make you predisposed to developing some types of cancer. So far, none of those individuals with Stuve-Wiedemann have developed cancer, so that's a good thing, but certainly causes a lot of problems. Management is fairly straightforward, and bisphosphonates may help, and new therapy may include read-through using gentamicin or a similar preparation. Next patient is a young lady who actually emailed me from her university and said, hey, I was told you were the person I needed to talk to, and I have a skeletal dysplasia. And so, as all good geneticists would do, I said, hey, can you send me some pictures of you in a bathing suit? Now, I must sound like a really trusting guy on the internet, because she actually sent me these pictures. So after I sent that email, I said, oh my gosh, if an IT person is monitoring this, I'm in trouble. So here she is, And she is indeed very short and has mildly atypical facial features, very limber, obviously. I can't do this. And has brachydactyly of her hands and her feet. And here she is. She sent me a lot of pictures of her through the years. This was from her senior high yearbook. And her radiographic findings demonstrated somewhat tall vertebral bodies, cervical and carpal bone fusion, and mildly shortened femoral necks. To me, her vertebral bodies certainly look a little bit tall. I'm trying to show you in her neck here the fusion that is occurring right here, and then over here, if I can get the fusion in the carpal bones right here, and these shortened femoral necks. So, CSCF is characterized by short stature and mildly atypical facial features, the brachydactyly and the synostosis in both the neck and the hands, and sometimes with deafness, and this young lady does have that, and cardiac defects. Here is a picture that's going to be in the article to be published soon, and this is a father and son who are affected with this condition and showing the different X-ray findings as well as phenotypic features. So this study was done in France on a total of 6 patients, and this patient is patient number 6, and so she is listed in that article. And what they found with exome sequencing was this candidate gene that encodes the transforming growth factor B activated kinase, or TAC1. So I will promise you that even though she has a missense mutation, there are functional studies in this article that show that this is indeed what we think is a causative gene. And deletion of that gene in the mouse limb mesenchyme leads to joint fusion, so consistent with what we're seeing with the carpal synostosis and the cervical vertebrae fusion. And it also causes craniofacial defects, so it can give you some of those facial features that we think are present there. So this is the article title, and the author is in press here and should be out soon, because I think it's been on its last revision now. And I'll be glad to answer any questions if you have them.
Curtis, if I send you an email, would you send me pictures in a bathing suit, please? Sorry, that wasn't my question.
She looks a lot better in a bathing suit than I do. I mean,
it was a great joke that you told. So
minutes later, I'm thinking, that was not a good idea.
Anyway, I was wondering, I didn't hear you say anything about her cardiac status. Does she have cardiac?
She had a small VSD that resolved spontaneously, and a PDA. She did have a heart defect, but required no surgery, okay? And she is, like I said, she's a graduate student. She's healthy, developing well. She had always thought that she had a problem, and because of her stature and some of her joint findings, she's having a hard time getting anyone to believe her and to accommodate her through the ADA Act at her workplace. That was really what was driving this. And again, she knew somebody in the genetics department at Clemson, and they said, oh, you need to call Dr. Rogers and get in touch with him, and that's how this all started.